So welcome everybody. Thank you for coming to our Buckeye Neurotrauma lecture this morning. My name is Kadar Hiremath. I'm the Associate Director for Ohio State's Chronic Brain Injury Program. So this is the Buckeye Neurotrauma lecture series, which is an open series to share Ohio State's research and clinical impacts, really tell like big stories about work that is being done here at Ohio State. And we do this in an open way so that people from communities or our partners in industry can also join in and enjoy the science. So today's talk we have Dr. Sheital Bavishi. She holds a number of positions here at Ohio State. With us, she is on our advisory board and is really one of our go-to specialists for all things TBI when it comes to the clinical care. So Dr. Bavishi is an associate professor in the Department of Physical Medicine and Rehab. She's also the residency program director there. And in addition to those roles, she is the medical director for the brain injury program at Dodd Rehab Hospital. She's the medical director for the Ohio Regional TBI Model Systems. And so in training, she's been all sorts of places all over Ohio. So started at Case Western, then did her medical degree at Ohio University, did her residency over at Cincinnati in their College of Medicine and PM&R, stepped out of Ohio for a little bit to do her fellowship at VCU and Hunter Holmes McGuire Veterans Hospital, and then came back to Ohio. In 2010, took a faculty position at the University of Cincinnati as their medical director of their TBI program, and then in 2013 came to Ohio State, and we've been really glad to have her here. She has a track record of research and grants in TBI and disorders of consciousness, and holds a number of leadership positions in the clinical space, and has also been recognized as a Castle Connolly top doctor for the past 3 years, top 10% in patient satisfaction at OSU each year since 2015. Very impressive. So Dr. Bavishi, talk to us today about advances in DOC education for providers. Thanks for coming.
Great. Well, thank you for the introduction. You make me sound a lot more accomplished than I feel some days. But anyway, just kind of a little background about me and why I do the disorders of consciousness. So in fellowship, I did my fellowship in polytrauma and traumatic brain injury through the VA, but also at VCU or Virginia Commonwealth University. And during that time is really when I got my first exposure to emerging consciousness programs. So the Veterans Administration does a really nice job, and they were one of the first to kind of do a more comprehensive emerging consciousness program. And so I really got my first taste of what that means. It's not a common thing to have in all residency programs or all academic centers to have a disorders of consciousness program. So I really had no exposure to it until I went into fellowship. And really, when I started thinking about what I was able to learn and do during that, we were helping patients that had devastating injuries, whether they were traumatic or non-traumatic, and really working as a group, as an interdisciplinary team with PTOT speech, our social workers, case managers, our rehab psychologists, our physicians, our nurses, our PCAs, to really create a comprehensive program to help kind of people emerge. And that's why in the VA system, it's called emerging consciousness. In the civilian or community population or academic centers, it's called disorders of consciousness. So, and really what we did with that was we recognized that patients need that early treatment. And so having that training, as I graduated fellowship and went into being an attending, recognized that we don't have those programs. And especially in Ohio, we didn't have one at all. And so, a lot of patients were from those programs, and I'll talk about that a little bit later in my slides, is, not getting the care, not getting the rehab, not getting the evaluations that they needed. So a lot of my work has focused since I've come to Ohio State in 2013 on disorders of consciousness, creating the only disorders of consciousness program that we have in Ohio, and also, sitting on some national committees on special interest groups and disorders of consciousness, presenting nationally and internationally on disorders of consciousness. And so this program what I'm going to tell you guys about, I was able to work with Ohio State and the Patient Care Innovation Program to really get some funding to create a program, because recognizing that there is not a lot of education for healthcare providers on disorders of consciousness. You don't really get education on this in medical school. I'd heard about neurology, and coma and things like that, but I never really knew what to do with those patients and how to take care of them. We didn't really get taught that in medical school. I really didn't even get taught that until my fellowship. And then after that, it's kind of been my primary focus of my practice. A lot of my practice is obviously brain injury is my whole practice. And so I take care of patients with varying brain injuries from acquired to traumatic. But this has kind of been my pet project, and then creating the program that launched in 2015, and that we've been very successful with over the last 8 years. So I'll kind of go in, and I have nothing to disclose. I have no financial disclosures, but I do want to say that I did receive grant funding for this project from the Patient Care Innovation Grants at Ohio State. So I just wanted to take a quick kind of survey of the audience. I just wanted to know, what experience do you have with disorders of consciousness after an acquired brain injury? And I couldn't figure out the polling thing to have you guys just poll. So you can put it in the chat, but these are the answers or the questions there. And I'm here for D, but I just want to know what everyone else is here for. So if you can just throw a B, C, or D, or multiple answers is fine, into the chat. I'd like to know who my audience is.
We've got an A. Some A's. A. So far, mostly A's, but I think there might be some challenge with the chat. So let me see if
Okay, no problem. But yes, so a lot of the people, and especially when you come to, and no CBI and no BNL, you have worked with patients with DOC, but there's a lot of people, not only, in the community, but even in our organization, that don't know what disorders of consciousness or DOC is. I know the types of referrals I get, and I question sometimes, do they understand what a DOC is? So, and I always will say CBI is a great organization. So that is the main reason I'm here. So, when we start thinking about what kinds of things can cause the disorders of consciousness, we want to talk about all the different types of acquired brain injuries. So we have the traumatic brain injury is really a lot of what we have data on. We have data on the CDC, we have data from, the model systems. Everything is really pointing towards the traumatic injuries. But we don't really have a lot of data on some of these other injuries that can result in DOC. So toxic encephalopathy, and then seizures are another one. If they have repetitive multiple seizures, hypoxia or anoxia. Anoxia is kind of one of our second to trauma. And then toxins are kind of our third. We do get, if people have posterior circulation strokes and they really hit their thalami bilaterally or some of their brainstem, getting those brainstem strokes can also result in a disorders of consciousness. So primarily these kind of four on the right side of your screen, alcohol, trauma, hypoxia, anoxia, and stroke are kind of the top tiers of what we see. And really trauma is our number one that we have the most data and research on for disorders of consciousness. So from the epidemiology standpoint, what I usually tell people is this data that I'm presenting is from the CDC, but the CDC hasn't updated anything since 2017. So this is the most up-to-date data I have. And I don't have anything for the last 6 years. So we definitely know that TBI is still it's a chronic condition. We know that we have, about 3.5 million new TBIs occurring in the US alone. Across the world, there's 50 to 60 new cases worldwide each year. But it's a huge economic toll, and the lifetime cost per TBI being, $500,000 at a minimum. Sometimes it's a lot more depending on, the amount of trauma they've had, the amount of surgeries and things, the length of stay in the acute care hospitals, and then, going into different facilities after. And then not only that, because it is a chronic condition, there are a lot of things that happen with funding for Medicare, Medicaid, and waiver programs and things like that also need to get included. So, the lifetime cost, to me, this $500,000 is very low. I believe it's a lot more. And I've seen some statistics that are more, but this is what the kind of CDC tells us. But about 1.3%, so it's a very small percentage, can result in a disorders of consciousness. And that's actually a prolonged disorders of consciousness. If you have a traumatic brain injury and you lose consciousness, that is a disorder of consciousness. But what I'm talking about is prolonged disorders of consciousness. And that's really the key. These are patients that are more than 4 weeks out from injury that are still in either a coma, unresponsive, wakeful, or minimally conscious state. And I'll kind of discuss what those states are in a minute. But really, those are the patients that I'm really focusing on in our DOC program. And so there's a lot of different perspectives on consciousness, and this is what makes it really hard. So this was a really nice article that was done in 2023, this year, with the BMC, and it really talked about the concept of consciousness, what's experienced, what's understood, and then there's different perspectives, especially from the delivery of care, the stakeholders, and then, discussing withdrawal of treatment. And so we've heard a lot, those of us that are in the rehab side of disorders of consciousness, we hear from patients' families all the time that says, in the ICUs and stuff, we were told by, the teams that, they're going to have severe disability, this is a severe injury, would they want to live this way? And they do talk about goals of care and the potential withdrawal of treatment. And a lot of patients are like, our families are, get that kind of gloom and doom at the beginning. And then they say, and if they don't withdraw care at that time, then they come over kind of from the rehab standpoint, and we get involved and we start talking about different things that we'll be doing. And so there's always that kind of dichotomy about what is your perspective, what's your experience of consciousness, what is that, what does that mean for that individual? But it also, as healthcare workers, we have our own biases on consciousness and what it means to us. What we really have to do is make sure that we're not bringing that and our thought process into these discussions with patients and their families. And quite honestly, we're obviously discussing with families. So I really wanted to kind of pull, again, this is the only other question that I'm going to ask for the audience to respond to if you're having trouble with the chat. But what is your concept of consciousness? So this, in the BMC, when they studied 27 participants and contributed kind of to looking at what the different what their thought process is on the different parts of consciousness, there was actually a total of 85 unique statements of what people thought was consciousness. And so they tried to bring those statements in and cluster them. And so they clustered them into these 6 areas. And when they clustered them into these 6 areas, they were really recognizing, what is the biggest thing that we need to do is kind of have more of a consensus on what consciousness is, but it's very different for different individuals. So these were the 6 areas that we kind of talk about. And these are the 6 areas that we discuss with patients and their families. But as a group, I just want to kind of take a poll how people perceive consciousness. And so let me know. 3A. Okay. So I'm getting a lot. Well, I got 3s and 1s. 2, 3s, 1. So mostly 1, 2, and 3. So presence, intentional activity, and experience of self. And really, those are a lot of what we talk about when we talk about awareness and being awake, and what does it mean. And participation in social interaction, responses, and unspecific reactions, again, are not things that we normally think of as consciousness. However, a lot of our testing that we do with our coma recovery scales, our MATADOC, our disorders of consciousness scales, and some of the other ones that you've probably heard out there, the WIM, the SMART, and all of those, they're really looking at social interactions, responses, and unspecific reactions. There is nothing in those scales that are asking about 1, 2, and 3. And so this is where there is that dichotomy, because people, especially that don't work with patients with DOC, they will look at a patient, and if they're opening their eyes and they're tracking and things, they're not going to think that they are conscious or consciously aware. But when we look at our scales, when we look at people that we're trying to determine, is there a level of consciousness, we're looking at really 4, 5, and 6. We're not necessarily looking at 1, 2, and 3. So this is where there is that dichotomy of what we're looking for. And this is why there is training that's needed, because we have this internal perception of what consciousness is with the intentional activities, presence, and experiencing ourselves. That's more those higher level. But if we want to know, is there just consciousness happening? And how do we scale those? The scales that we have that are actually validated scales are really looking at 4, 5, and 6. And especially that repeated responses. So when we start thinking about consciousness, like I said, what does it mean to be awake versus aware? And so what are the different levels of arousal and awareness, and how are they clinically used to identify the stages? So, there's a wakefulness, which is kind of eye-opening, but then there's the awareness. So that's where we're kind of talking about, can they respond to external stimuli, internal stimuli? How can that be integrated? So there's, you look at command following as one of those, but command following isn't necessarily one of the tenets on the CRSR that will say definitive emergence. It's actually functional object used. So when you hand someone a hairbrush and they go to brush their hair, they know what the object is, they know how to use it, and they use it appropriately. That's a functional object use. And that's actually a higher level than just following a command to give me a thumbs up. Now, if they can do a thumbs up 3 times in a row, then, there's a difference with the repeated response. So, thinking about that when we think about consciousness. And so, when we look at the DOC or the disorders of consciousness, we're really looking, and like I said, from my practice, I'm looking at prolonged disorders of consciousness, or the disorders of consciousness over, 4 weeks. And really, like I said early on, these are the primary areas that I'm really looking at in our DOC program. So trauma, vascular events, the hypoxic or anoxic brain injuries, the toxic and metabolic, and some of the infections as well. And with the recent pandemic, we talked a lot about, different viral infections, West Nile virus, HSV and syphilis, and all of neurosyphilis. They can all be viruses that can create, neurological deficits, and potentially could lead to a disorder of consciousness. And so when we start thinking about the different levels, like I talked about earlier, there's the coma, which is where people, eyes are closed, there's 0 responses to the environment. They're not even spontaneous eye opening. And this usually is very short period. A lot of the times we'll get patients and their family, patients' families saying, well, they were in a coma for 4 weeks. And it's like, but there aren't really. And that's where, as the healthcare providers and physicians and, all of us that are working with these patients and their families, we have to talk to the families about, coma really means how long were their eyes closed. And if they say, oh, well, they started opening eyes on day 2, so they were out of coma. But then there's the unresponsive wakeful state, which was previously known as the vegetative state. And the only reason I still put VS on here is because it still hasn't, UWS hasn't still come into mainstream to use it. But really, it's an unresponsive wakeful state because their eyes are open, they're awake, but they're not responding to the environment necessarily. They don't have that environmental awareness, but they do have a sleep-wake cycle. And then minimally conscious is where there is environmental awareness, there might be tracking. And Dr. Shannon that I work with, she always says this, the hallmark of this state is they're consistently inconsistent. So they can do something one time, but then they can't repeat it. And so the repetition is also a part of this, the coma recovery scale that we really hone in on when we're evaluating someone for consciousness. So as a physiatrist or physiatrist, if you're at Ohio State, we're called physiatrists, but it's the same thing. But what is my role? And really what my role is to establish and confirm the diagnosis. So I really want to make sure that the person I'm saying is in a disorders of consciousness is really there because of their acquired brain injury and not because of some reversible cause. Look at all of the comorbidities and manage them, and then look at medications and make sure that we're pulling off sedating medications, considering neurostimulant medications or neuromodulation. There's some research going on in some of these areas. I'm not going to talk about them because it's not standard of care for like a deep brain or transcranial direct current stim or the transcranial magnetic stim, but they are in the literature and being studied at this time. And then interdisciplinary rehab. Now that we do have a lot of data on and how specialized early treatment can really help patients. So, you know, as me as the physiatrist, I'm really kind of overseeing this role. And that's really what we want some of our community providers and in nursing homes and LTACs and things to understand is that they, you know, they can't just say someone is in a coma or minimally conscious unless they really have ruled out other things, they've weaned off other medications. And the reason for that is because this was done back in 2009, but they actually did, they looked at patients, I can't remember the exact number of patients at this time, but they looked at them and they tried to determine their levels of consciousness using CRSR and what they were actually labeled as by their whatever provider that was working with them, whether it was a physician or a nurse practitioner or therapist. And about 43% of those were actually misdiagnosed as a vegetative state when they were really in a minimally conscious state. And there was actually another percentage of like 20 or 30% that were really conscious, but you know, noted to be in a minimally conscious state. So that's a huge percentage of individuals that are being labeled in a disorders of consciousness that may not actually be in DOC. The other thing is we have to rule out any reversible causes. And one of the big ones that I'm always doing is pulling off as many medications as I can, looking for seizures or other things that haven't been treated. And then, you know, this is kind of just a listing of all the different complexity of disorders of consciousness. So these are all the things as a physician or nurse practitioners or, you know, medical providers that we're actually doing for patients and reviewing and evaluating. But then if you look at what consultations we're bringing in, we're definitely pulling in our rehab consultants, our neuropsychologists, and then we have to have access to some of these other consultants because, you know, some patients may have visual problems, they may have hearing problems that's leaving them in a disorders of consciousness, and they may actually be more conscious, they just can't hear us or they can't see us. And then, you know, if needed, if there are surgical interventions or, you know, managing seizures, we're bringing in like the neurologists and the neurosurgeons, et cetera. So it's really from a medical standpoint, this is what we're doing. But we're also looking at the timing of rehab. So this was done in 2013 where they're looking at, or it was published in 2013, where they're looking at timing of rehab and from days of injury and then how they progressed. And so when we look at this graph, and it's a little blurry here, I'm sorry about my picture, but bringing that from this article in 2013 that SEAL did, is that the longer you are out and then you make it to, you know, inpatient rehab or any kind of rehab, the less you have of a FIM score, or FIM means functional independence measure. Whereas if you get to, you know, rehab earlier, there you have a much bigger kind of gap with that FIM score. So you definitely want to see that those that came into the emerging consciousness program, you know, who emerged, they had a much higher FIM gain or functional gain than those that came in a little bit later. So getting that rehab early is necessary. And this is another reason why we wanted to bring an education program out there so people can recognize that. And then we talk about prognostics, because a lot of the times that's what I get asked about all the time. Well, what is the prognosis my loved one is going to wake up, and, all of this. And we have limited data. We have imaging, we have, how they're responding, we have their CRSR scores, but I don't have, like fMRIs are still not standard of care. I don't have anything, and EEGs don't necessarily correlate with how people are thinking and stuff. So I don't have anything to really talk to patients about when we talk about prognostics. I always tell them if I had a crystal ball to answer that question, I wouldn't be working in academics. I'd be working somewhere else. But, that's the point, is that, but it's not just me as a physiatrist that get asked that question. Everybody, primary care physicians, surgeons, whoever comes in contact with that family is being asked that question. So, we really want to make sure that we have information out there for the community so they feel like they can help take care of these patients and counsel the families. We started talking about outcomes. So we also have NIDLR, the National Institute of Disability and Rehab Research, and then we have the TBI model systems, and they look at functional outcomes for 5 years post somebody with a disorders of consciousness, and that were admitted to IPR or inpatient rehab. And 68% regained consciousness during their inpatient stay, and 23% emerged even all the way to beyond post-traumatic amnesia during their inpatient stay. So they had almost 400 individuals that they reviewed. And in that, they broke them up into like an early recovery that they were following commands before discharge, and late recovery, they weren't following commands before discharge. And so, when they start talking about those that recovered earlier had by 5 years higher level of functioning, especially physical functioning. So, and a lot of them were physically functioning almost up to 36% independently at 5 years. So really getting people into inpatient rehab and really working to even just command follow. They may still be, wheelchair dependent. They may still need total assist with their ADLs when they leave inpatient rehab, but the fact that they're able to follow commands before inpatient rehab has a better prognosis for them down the road at 5 years. So, so really thinking about that, is why we were like, well, we need to identify these patients that are really going to be able to participate and function, and we get to them early, so that way we can get them, to that success rate at the 5-year mark. And so a lot of the things that were, this was just more data from the study in 2013, that was published in 2013, but, really a lot of it was physical functioning. The cognitive functioning is the one that was not as high, and that people still may not have been able to sustain gainful employment or driving and things, but physically they were gaining that independence. So again, this was in the late recovery group, though you didn't see as robust of independence at 5 years. You still could see it, but it wasn't as robust as if we had an early recovery group. So I always tell people the quicker you get better, the better you get. And I tell their families the same thing. And so this is just basically the charts kind of representing the early and the late and where people are functioning. So the dotted lines here on these are at 5 years. And then the solid lines are when they discharged from inpatient rehab. So really you can see here, where you're in the B is the late recovery, but not completely independent. But then when you look at your early recovery, you can see where they score a lot higher on their FIM scores than those that had a late recovery and that weren't completely independent. And then the number or the percentage of those that are, later recovery and gaining independence is up here in B. So, having this really shows you how early recovery can really affect a patient's prognosis. And so, like I said, there was a statistically significant recovery, but after 2 years, it started slowing down. And so the scale started becoming a little bit more even. So we really want to get to these patients in the first 1 to 2 years. That's why it's very important to identify people early and get them into programs. And so when they also, looking at this, they also looked at, what is more favorable and what kinds of patients are the ones that are the most often that are going to have those good outcomes. And traumatic brain injury was the top of the list. That's why a lot of disorders of consciousness programs are really focusing on traumatic brain injury. That's why we have a lot of data for traumatic brain injury. And then those that come into IPR, when they're at higher level, of course, minimally conscious versus if they come into us at UWS. So a lot of the disorders of consciousness programs are really looking at the type of injury and what level they're at. And that's why it's really important for us to have our community partners having really good documentation of what the patients are doing. And I especially look at those therapy notes from the community. And that's why we really, started talking about, well, I need that information and I need it from the community in order to see if this patient's a candidate for our program. And I really need to make sure that I teach everybody how to get me the data and what I need to do. So with that, they also did 10-year outcomes, and the only difference between 5 and 10 years was if they were following commands prior to the 28 days or prior to that, we started putting them into the prolonged DOC. There was greater functional independence at the later time points. So, so the 10-year really didn't have a lot of difference between 5 and 10. So really that first, 2 years is what matters the most. And then even up to 5 years, between the 5 and 10, we're not seeing as robust of changes from independence. So we need to get these patients early. And a lot of DOC programs, and ours included at OSU, is taking patients and when they're 12 months, within their first 12 months of injury, because that's when we can have the highest impact at that point. So, this is just a table showing what I was talking about with the outcomes. And so, but this also talked about the different types of injuries and what we're seeing from their FIM scores, their Rancho scores, et cetera. So, and the traumas have the most data, blast and penetrating, and then other traumas, and then your non-traumatics are kind of your anoxics have, and if you can see, they have the least likelihood of emergence. So really, these are, like we talked about, these are the benefits of a DOC program, and it's really optimizing patients, optimizing, doing family education and support, preventing complications, because we do know that this is a marathon, not a sprint. And so I'm not gonna admit somebody and be like, they're better. It's gonna take months, it could take years, but we definitely know that we need to start the process early. And then, but there's a lot of difficulties in DOC programs. Insurance payers don't usually pay for disorders of consciousness because you're like, well, if they can't follow commands, how can they do 3 hours of therapy a day? Our lengths of stay in inpatient rehab in the community are, very short. I mean, I get 2 to 4 weeks with patients. Whereas in the VA system, their emergent consciousness program is 90 days. The amount that I can do with 90 days and their median length of stay is 132 days. Those of us that actually request 132 days and out in private or academic or community centers, we're going to get laughed at by not only our insurance payers, but also by our colleagues and CMS. So we have to really be judicious about who we're bringing into these programs. But the big key for that is recognizing these patients earlier and having more data to support them coming in. And it takes a lot of resources. So, objectives of my program. So this, this education program for healthcare workers, and like I've been alluding to throughout all of this, is really, I want to get training for the community, working with this population. One, reducing burnout for the staff, but also, and risk of injury, but also getting the most optimal care for the patients. I want to facilitate a transition from a place like Dodd to outside facilities, because, once they're in the disorders of consciousness program, sometimes families can't take them home. And I want to make sure that I'm training other facilities on how to take care of patients in a DOC and ensure they're still getting therapies and the care they need to prevent complications so that they can have the time for their brain to heal. But we also want to make sure that they're being recognized early, so that way we can get them into our DOC program as well and get that specialized early care. And so, and the other big key is educating staff on this coma recovery scale revised, because as we talked about, we all have very different perceptions of what consciousness is, and the scales are actually looking at, like I said, that 4, 5, and 6, those repetitive movements, those following commands and things like that, and social interactions, not our perceptions of, quality of life and things like that. So really making sure that we have, objective data that our colleagues in the community know how to use and know how to do. And so this was actually, the Ohio Regional Brain Injury, they actually create a biennial report on the impact of TBI. And this is in Ohio. And the reason I put this in here is because our program's here in Ohio. I'm in Ohio State, and we really created this to impact Ohioans. And so when we started looking at the data of what age groups of people are getting injured the most, and in our trauma registries, and a lot of them in these 75 to 84-year-olds, a lot of them cannot tolerate 3 hours of therapy right away. And so they do end up in skilled nursing facilities or long-term acute care hospitals or some other level of care besides inpatient rehab. And so really, but these are the ones that also don't have the greatest prognosis. And we really want to focus on, the patients here in the middle that are, have a good potential and get them in early. And so, we started talking about what are the anticipated number of patients that could benefit from this program. And it's really, the patients that go to inpatient rehab and making sure that they can, all inpatient rehab units feel comfortable with taking care of patients in disorders of consciousness. So a lot of what we've been doing with our training is going to other inpatient rehab facilities and helping train them on disorders of consciousness. They may not create a full program, but they might be able to help us with at least seeing or getting patients, or when they get a referral, knowing, hey, this is a DOC, send them to Ohio State, et cetera. And then skilled nursing facilities. So, the population of people that are leaving the acute care and going into skilled facilities is getting higher and higher. And so we want to make sure that we're training our skilled nursing facility colleagues as well. So that's really the goal of our education and training is not only if we can train the caregivers and we can train the physicians and the clinicians taking care of patients outside of an inpatient rehab that's specialized like mine, then patients can have a potential for a better outcome because they're preventing, complications. They're educating families on what it is, what they're doing. And then they have a higher chance of discharging home and improving their quality of life. So really what I wanted, creating this, we wanted to have more of a collaboration between our rehab team here, our DOC team, and local subacute, acute care, long-term acute care staff to really help them understand, recognize what DOC is, what the DOC programs are, and like how to, impact that and get them the right care that they need. But in reality, the programs that are actually seeking education are inpatient rehab hospitals. I mean, out of all of the ones that have heard about our program, the inpatient rehab hospitals are the ones that are reaching out the most. And I think it's because they're rehabilitation providers. We have physiatrists there, we have therapists there, we have psychologists, we have social workers, case managers. They're all focused on, taking care of patients outside of the acute care settings and getting them, along the progress to being able to get home. And so it was really interesting to me because I created this program to think I'm going to really try to impact skilled facilities because that's where a lot of my patients are going when they can't follow commands and they're medically stable and insurance is denying them to come to inpatient rehab. But why? So, and then the other piece is the long-term acute care hospitals, because a lot of times patients end up on ventilators and need to be weaned from the ventilator. So the long-term acute care hospitals also are seeking a lot of that training so that they know how to optimize the patients to get them to rehab. So why not skilled nursing facilities? I have some theories out there as to why skilled nursing facilities, are not seeking out this education, and a lot of it has to do with staffing and timing and funding. But I also think a lot of it has to do with you don't know what you don't know. And so a lot of what we need to do is really reach out to a lot of these facilities and really, start showing them the importance of recognizing patients. But a lot of the times, skilled facilities aren't taking a traumatic brain injury patient because they are a lot of care, a lot of work, they're too complicated. And so they may not be seeing as many in the skilled facilities, but then where do these patients go? And there isn't a location, especially in Ohio, for patients to go if they don't qualify for a long-term acute care, and skilled nursing facilities can't take them. So I really want to make sure that we're training all the different levels out there so that patients have a place to go. Another big thing is I wanted to shout out to the, Model Systems Knowledge Translation Center. This is a great place to go for clinicians and families to get a lot of information about disorders of consciousness and learning about some of the terminology we use. Tons of fact sheets on the MSKTC. It is something that the TBI Model Systems works very closely with as well, reviewing those fact sheets. So, there is that education out there, but unless we create more of a comprehensive kind of seminars and give CME and stuff, a lot of people aren't going to some of these sites. So that was a real goal of our program. And, we've only really launched it last year. So, we are definitely seeking to get more of our education out there. But our first education that we did was for Nationwide Children's Hospital, and we thought it was very successful, and we've had a really good collaboration with them, and they're actually working on opening a disorders of consciousness program down the road. So I think having more of this and the ability to go and train is really necessary, and making sure that we recognize that it's not just about creating the DOC program that we have at Ohio State and putting things on our website, but it's also about making sure that we expand and we're giving our knowledge out to everyone else. So that being said, tons of references that are on them, and I believe the slides or the video link will be sent out to everybody, so you'll have a chance to look at those slides.